So next is iron deficiency anemia. It's V22. A 55-year-old man is referred to you with an iron deficiency anemia and weight loss. What are the likely causes of anemia? A very broad question to answer. So gastrointestinal blood loss from the gastric or colorectal cancer, celiac disease, renal tract malignancy. So it depends if the patient is eating and drinking healthy food. There's no loss. How will you assess him in clinic? So first of all, I will take history. I will ask about red flag symptoms like rectal bleeding, change in bowel habit, dyspepsia, dysphagia, abdominal pain, and drug history like NSAIDs, PPI, and anticoagulation, and family history of bleeding disorders. Then I will do examination for abdominal masses, lymph node in the neck and the groin lymph node. Review the blood test from the GP and repeat if necessary, and send a urine sample. He has lost 1 stone in weight over the last couple of months. There is no history of rectal bleeding or change in bowel habit. How will you investigate the patient? In accordance with the British Society of Gastroenterologists, screen for celiac disease, anti-tissue transglutaminase antibodies. If they are positive, fine. If negative, then they need D2 biopsy. So OGD D2 biopsies if tissue transglutaminase is negative, and then colonoscopy. What other options are available for visualizing the large bowel? So colonoscopy is the preferred test. The risk of perforation is 1 out of 700. Mortality following perforation is 10%. Flexible sigmoidoscopy is not good enough as it will not visualize the cecum in the right colon. CT colonography is an option for the patient who are not fit enough for colonoscopy. Barium enema is least preferred option. There is a risk of perforation of 1 out of 10,000, mortality 1 out of 60,000. So he has an OGD and tissue transglutaminase test was positive, and D2 biopsy confirms celiac disease. Your ST6 asks if he can cancel the colonoscopy. No, the patient still needs the test. According to these guidelines, any patient more than 50 or with marked anemia or a significant family history of colorectal cancers still needs a lower GI investigation, even if the celiac disease is confirmed. What if the OGD and colonoscopy were normal? Would you discharge the patient back to the GP? So I would ask the GP to start iron supplements. If the patient is still persistent anemic or transfusion dependent, then I would consider small bowel capsule endoscopy to rule out telangiectasia. And a 46-year-old lady is referred to you with an iron deficiency anemia and abdominal pain. How will you investigate her? I would take a thorough history and also check whether she is pre or postmenopausal. Only postmenopausal women need an OGD and colonoscopy unless specific symptom or strong family history warrant investigation. So premenopausal women should be screened for celiac disease only, essentially.